Welcome to Talk Dizzy to Me, the show that brings you a comprehensive look into the complex field of dizziness. Now here are your hosts, vestibular physical therapist Dr. Abby Ross and Dr. Danielle Tolman.
Hello, everyone. Welcome back to Talk Dizzy to Me. My name is Dr. Abby Ross. I'm a vestibular physical therapist and neuroclinical specialist, joined, as always, by my colleague, Dr. Danny Tolman. She's also a vestibular physical therapist. And today we have a guest on. I'm just going to say this up front. I've never seen so many letters after someone's name, and I don't even know what all of them mean. But it is Dr. Mike Studer. He's also a physical therapist, and we are going to talk about all things neuroplasticity. I just finished refreshing my brain on a TED Talk that you did, actually. And, you know, there's a part of it where I was listening kind of in the background, and I'm like, what is he saying? Because there's a part of it where you use something to capture the audience's attention again, and you say something like, you know, after concussion, you should stay in a dark room for 2 to 3 weeks. And neuroplasticity will help happen all on its own. And it really pulls the attention of the audience back in. So, Mike, thank you so much for being here today. I can't wait to jump into this topic with you.
Thank you. It is my pleasure to be here. I appreciate the invitation and the opportunity.
Can you go ahead and give our audience a background on what you do, what your passions are, what brings you into this space?
I can. So I've been a physical therapist since 1991. I'm one of these very odd people that has a bachelor's in physical therapy, a master's in physical therapy, and a transitional doctorate in physical therapy. So I got 3 separate terminal degrees, if you will, in physical therapy, all with focus on neurologic physical therapy because it's been my passion since basically 1988. So I've been a practice owner, always a practicing clinician, every aspect of the continuum of care. Obviously, I've done a TED Talk. I do a lot of continuing education lectures throughout the world, all 50 states, 15 countries, 5 continents. But doesn't matter whether I'm writing articles, teaching at a physical therapy program, which I do as well as an adjunct. Always, it comes back to my personal connection with a patient. Everything that I do is built on that.
I love that so much. I'm so big on relationships and connections, so that makes perfect sense for this topic as well. And by the way, audience, there's something else we're going to be talking about, which watching Dr. Studer right here made me remember this. He is currently dual tasking. He is walking on a treadmill while participating in Talk Dizzy to Me today. So if you're watching on YouTube and the movement is bothersome, please hop over to Apple Podcasts, Spotify, wherever else you'd like to listen to the episode today. Let's get right into it. So first of all, I think we need to define what neuroplasticity is. What is your definition? And again, in your TED Talk, I really like there's an analogy that you give in the TED Talk, and maybe you can share that today.
Oh, I'll even start there. Thank you. I appreciate it, Abby. So the analogy is really the consideration of making connections between towns, right? So that we can travel and to be able to pave these connections from initially being just a walkway where we've trampled down tall grasses, and then we have cleared a pathway, and now we've paved a pathway to become a road. That just expedites our capacity to travel. And so really neuroplasticity, as we first thought about this, speaking in the late 1990s and early 2000s, was merely the dynamic capacity to reorganize connections and to make more connections. And now we have understood through more sophisticated research that it truly moves into the analogy that I'm speaking of. It's not just more pathways, connections, it's actually expediting the efficiency of those pathways and promoting the infrastructure, being neurotrophic, feeding the nervous system so that we have the most capacity to proliferate connections and improve their stability and viability. So if we were to make it reductive and simplistic, Neuroplasticity is the dynamic capacity for the brain to reorganize connections and the permanence or presence of those connections.
In the realm of life specifically, or life in general, I should say, before we get more into rehab, what core principles do we want to think about when we think about neuroplasticity?
I love that. So we have to understand that neuroplasticity, from a practical standpoint, is the fundamental process that underpins all learning. Okay? So that means that any type of movement we're trying to learn, any type of fact or trivia we're trying to learn, and in addition, any event or episode or situation or context that we'd like to memorize, it must be imprinted in neuroplasticity. Now let's go to your question and let's consider principles. In 2008, a seminal article written by Klein and Jones that many of your listeners, and some would not be aware of, identified 10 common principles that could be agreed upon in a consensus fashion for neuroplasticity. I'll spare you the diatribe of going through all of them, and let's just understand that we have largely coalesced around the importance of intensity, difficulty, repetitions, salience, and task specificity. And what that really means is, and this is so beautiful, if we're intense enough in practice that's meaningful, the individual might put a memory target or a post-it note on that event, movement, or fact, later to be consolidated and created structurally in the brain during sleep that night. The intensity matters to be able to create that, hey, that was important, significant, felt good, tasted good, might need to remember that. Let's put that away and consolidate it. Repetitions are beneficial for perhaps only the same reason. Repetitions can improve the significance. Intensity itself, one repetition, one exposure, traumatic, pleasurable, or significant, can do it. But repetitions can help to improve the likelihood that there's going to be a post-it note, remember this later during REM sleep. Then the only other two that would be appropriate for our discussion today is just that task specificity and salience, which means it's meaningful and important for me to grab this information. So now the learner has yet another reason to put a post-it note. That's where I would wrap that up.
Yeah, there was, when I look back to how I would explain exercises as we move more into the rehab realm, when I look back at how I would explain things before really, I guess, expanding my knowledge and how I approach patient care, I wish I would have talked more from a neuroplasticity level versus just saying, hey, you're going to walk down the hall and look right and look left. Like, why are we doing this? And why does repetition matter? And how can I make this meaningful to you? And now when I approach patient care, I start here and then go more narrow. Like, I figure out what the patient wants to do and then develop my program based on that, because like you said, what's meaningful matters. There's another part of a talk that I was listening to of yours in which I'm going to use this moving forward. When we talk about repetition, you talk about, well, you might start that connection on a dirt road and it's super bumpy and it's uncomfortable. But the more times your wheels go down that road, the smoother the path becomes, the more pleasant the ride becomes, the more automatic it is. And I think that's perfect when explaining, why am I asking you to do these exercises over and over again, or this movement over and over again? That's the very reason. So now let's get a little more narrow. Let's talk about vestibular rehab specifically, and what have we learned and how have we deepened our understanding of neuroplasticity because of it?
You know what? I'm going to try to just not overstate this, but it's going to be hard not to overstate it. I get a little hyperbolic at times. I get very excited about these matters. To me, vestibular rehabilitation is the initial proof of the existence of neuroplasticity. And we could talk about this for hours, but I'll be succinct here to say that the understanding that neurons that fire together will wire together is evident in persistent pain, in post-traumatic stress disorder, and let's also say in vestibular rehabilitation. When I try to get out of bed this way, I'm expecting to have vertigo. When I turn my head when I walk, I expect I'll have dizziness. If you're going to ask me to ride in the back of a car, I expect I'm going to have nausea. Neurons that fire together, that movement or that environment will wire together, I'm going to experience this. We call that predictive processing. There's other terms you can use for it, but that's the most commonly agreed upon term. During vestibular rehabilitation, we have proven that we can unwire the neurons that fire together so that with neuroplasticity, reorganization, they no longer wire together. I can feel okay with riding in the back seat, turning my head, getting out of bed, and I didn't provoke these symptoms. How? Very briefly, utilizing something, and again, I'm oversimplifying, so apologies for those listeners that are very astute. I am being reductive. By using exposure-based therapy, we're going to call it habituation for today's purposes. Some will want me to call it adaptation. That's okay. Exposure-based therapy can reduce the neuronal fire and wire together. Now, why is that so important? Because it extends beyond VR, vestibular rehabilitation, into pain neuroscience, into psychology. I can make you less fearful of spiders, less fearful of bending over at the waist to pick something up off the ground through the same, now we'll call it exposure response prevention in psychology, or I'll call it graded exposure and generalized movement in pain rehabilitation, but all of it comes from vestibular rehabilitation, habituation.
It's interesting to bring that up. And just, starting off with this, the nerves that fire together or wire together, we see that so commonly when we are working with this patient population, because by the time they make it to us, they have been in this chronic state for a while. So they've leaned into those maladaptive behaviors. They're avoiding certain movements. They always associate that. So whether they're not moving well when they come see us, or even after we clear up an episode of Beep and BV, they still report feelings, mildly symptomatic, like they're going to go when they lay down or sit up out of bed, because it's just kind of ingrained there. We see that so often, and it's great to have an idea of why that's occurring.
Yes. And, we'll talk about this later today, but that predictive processing of I'm going to get these symptoms will also lead into our discussion of fear as well, won't it?
Well, that's something that, we have to kind of address when it comes to teaching patients about why we're doing our exercises, how they're going to help, because it takes a lot of convincing to tell somebody to do something over and over and over again, especially if it makes them feel uncomfortable or they're worried about being triggered into another episode. So that makes a really good point of that, of having to really hold their hands and educate them, let them know why this is happening, why this is going to make them feel better, and how we have to get over that initial hump in order to see improvement. So what are some things that clinicians can do to harness neuroplasticity, really integrate it into their treatment plans, whether it's, vestibular therapy or otherwise?
Here's where I'm going to come back to my last statement as I was introducing myself. And I'm going to tell you relationship is where it all comes to the crux. And it is the most important attribute to the size of the funnel of, is all of this that I'm putting into the mix going to pour into something that's successful or not? I think one thing, Danielle, that I would suggest clinicians would do is lean in, listen to, include the opinion of the person you're working with. because I like to say that you can't spell precision without person. Literally, those letters are sitting in there. And I would tell you, I talk about the soft skills, and I talk about, precision of diagnosis and specificity and dosage and everything. But I'll tell you, this is the reason why I say you've got to lean in and speak to and listen to the person, because when the person knows that their response is being heard and also being included, that provokes your nausea up to this scale based on your perception, based on what you told me. Now I'm going to change the delivery, the dosage, the intensity, or the frequency, or I'm going to move to a different task. And if we can simply do one thing better, it's listen to the person and show them we're including their preferences.
I just want to sing your praises right now, because this is another topic that I now touch on at every single initial evaluation that I have. I tell them that our plan is something that is formulated together. I rely on your feedback to make adjustments, and even when a next session is appropriate, because our clinic's a little bit different than some in that we are cash pay, right? So I don't want this person coming to me if they've done nothing of what I already recommended, because I have no feedback. I've got nothing to work off of. I can continue to educate. I can switch up their plan, but I'm not basing it off of their feedback. And I want them to really treat us as a team versus me just telling them what to do. And this, shifting gears slightly, you did mention this already, and you really also hit home because you mentioned the word spiders and fear of spiders.
Right.
I recently spent some time at my parents' house, in which they have way more spiders than it's just bad. It's bad. It's bad, especially in the summer. But, by the end of my stay there, I was finally able to tolerate the spider being in the same room as me and not freaking out, because I had exposed myself to spiders over the course of the month so much. So let's talk about fear in real life, and then again, specifically in situations where we learn this is going to make me dizzy, or this is going to cause me pain, or I will feel nauseated from this. How do we address this?
There's a couple of very scientifically based techniques to use to address this. We're going to keep the umbrella of the person's tolerance and preference for the volume, the intensity, the frequency of our dosage of exposure-based therapy. But all of these approaches are grounded in a singular exposure response prevention, okay? So when we have a prediction that this is going to cause me these types of symptoms, we have what's known as a prediction error that is the ultimate underpinning for the growth of the human being. They predict they're going to experience back pain when they reach to the floor. However, on 2 or 3 of those 10 trials that they try to do that with exposure therapy, they're surprised pleasantly. We have a response prediction error, and they're pleasantly surprised that on 3 of those trials, they didn't have back pain. The same thing can happen for you. I had an interaction with a spider, and I'm surprised it did not trigger me, provoke sympathetic reactions, or however you manifest that. The same thing's true in vestibular rehabilitation. I expected to be imbalanced. I expected dizziness. I expected vertigo, or I expected nausea. Our 4 main flavors, if you will. When we can, and our patients can, experience a repetition or a condition that is non-provocational, we get a response prediction error. That generates a dopaminergic connection that says, I like that. That wasn't as bad as I thought it was going to be. Maybe it won't always need to be like this. So now we work with the individual to determine if we may be permitted to introduce more of this same, or higher intensity, spider closer to you, or more frequent. And then the same is true in VR. Again, I'll use that for vestibular rehabilitation, not virtual reality. Head speed, head direction, background, number of repetitions, duration, frequency, etc. So now we're saying through motivational interviewing, can you tell me how that made you feel? Are you surprised that that didn't provoke the symptoms quite as high? Would you be up for experimenting with another repetition? So I'm utilizing the optimal theory of motor learning, providing autonomy. I'm utilizing motivational interviewing by allowing the individual to reflect. And then I actually also utilize affirming listening techniques with what I've heard from them.
That's great. And you remind me, actually, I think the APTA or the ANPT, one of them, maybe it was the ANPT, they just did a series on motivational interviewing. Did you see that?
I did not get a chance to see that. I have been ultimately way busier than I needed to be over the last, I believe that occurred. They may have had 2 parts already play, but I've missed both of those if they've played both of them.
Yeah, they did. They did. But also, how can we use that in our sessions to really garner the results that we want? And this is perfect. Now, when we have fear, can you explain what's actually happening in that threat perception and how we can then say, hey, we need to roadblock that particular connection and rewire it a different way?
Mm-hmm. Absolutely. And it has a degree of similarity to what we've already talked about. But first, let's address the initial part of your question. What's happening? I'm going to also be oversimplistic and reductive here and say that the amygdala is not the fear center. It's interconnected with our attention, but it has a large degree to do with our fears and perceptions. So let's say that the amygdala is actually sensitized when we come to a familiar environment or experience. I've got a pitch today against that really difficult team. I've never got a hit off of this pitcher before. There's going to be spiders. It's going to be dark. I hate driving in the dark, or I'm going to have to move my head side to side. Anything that could provoke previous experiences that you memory tagged. Okay, so now we come back up to the top. That one experience was significant to me. I put a Post-it note on it. I slept on September 19th, 1989, and boy, I never want that to happen again. So now you pull that back up when the smell or the music or the sound or the visual surround feels similar to that previous, and the amygdala says, I warned you, you don't want to get in this situation again. And the attention centers, plural, dorsolateral prefrontal cortex and associated, they interconnect to motor systems, to visual systems, and all of the sensory systems. Sympathetic nervous system comes up and says, what can we do to protect so we don't experience that sensation again?
Is there a difference between fear-based behaviors or symptom-limiting behaviors? So symptom-limiting behaviors that might make somebody move differently unconsciously, that they're not, specifically tying that to something, but they're moving differently because of the way they feel.
The science on this is developing, and I'll tell you, I've worked with my colleague, Dr. Merrill Landers at UNLV a little bit on this. It's not precise and perfect science. What we have established is fear-avoidant behavior. Okay, that's easy to recognize, right, Danielle? This person's choosing not to participate. They're choosing not to get up. They're going to stay in bed. Fear-avoidant behavior is easy to read. However, what your very intelligent question begins to extract is fear-adapted movement. Okay, that's not in the literature yet. We're working on this a little bit right now. And it is exactly what you're saying. What and how is someone moving that reflects, even if they're not willing to speak about it, that they are fearful that they might provoke movement or sensory-based and uncomfortable situations, meaning in an individual recovering from vestibular impairment, as we all know, they might reduce arm swing, but more likely they're going to reduce head rotation, but more likely they're going to take a very intentional approach toward turning or rolling to get out of bed. So what we're watching for are some of these whole body movements that potentially include co-contracted movement, that don't include more sudden movements, limiting rotational efforts typically. Now, again, if an individual becomes dizzy with head nodding, they're going to change in that plane of motion as well. So what we're watching for is the intentionality, the difficulty handling, this is important, distractions, because they're focusing so much cognitive energy and muscular energy to co-contract and stabilize that now they also become exhausted. So we're looking for characteristic movement patterns, but let's go a step further. We're also looking for intolerance to activities that normally would have been automatized for them. Normally they could do like the back of their hand or remember like the back of their hand, and now they can't fold in a dual task because just trying to manage fear or to prevent symptoms from being triggered, now they can't load in a secondary cognitive activity.
What I like about everything you just said is that you mentioned you have to watch, you have to look, you have to observe your patient, because I have found a lot of people aren't even aware that they're limiting themselves or changing their movements. I'll have somebody come in and, I'll ask them about their condition and their history sounds beep, 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 beep like, but they say, oh, but it's been getting so much better. Doesn't even bother me anymore. And I go, that's odd. Have we done any maneuvers? No. Oh, it's just you've been avoiding bending, lying down. I ask them, what happens when you lay flat? Like, oh, we can't lay flat because it makes me dizzy. Okay,
Yeah.
so we're not triggering symptoms, and that's why you're feeling better. But I guarantee you, if I lay you down on this table right now, the room is going to spin. So it's
Oh my
interesting to
gosh.
have to look at that and tease that out, because some patients just aren't even aware.
Yeah, and that's exactly right. And what I like to do is when I observe it is I made some observations of how you chose to get out of bed there. And I'm wondering if you have any reflections first about how you chose to get out of bed, because I'd like to hear from you first. I find that most, not all people are like every other person, but a lot of times patients love it when I give them a chance to speak first. And so when I see something that calls to my attention that they're experiencing fear-adapted movement, I'd like for them to show me they recognize that before I call it to their attention, because now I'm creating an individual that can walk away from the clinic and begin to notice it, reflect it, and also mitigate it without my presence.
Absolutely. And whether it's fear-driven or symptom-driven, it takes us back to the pieces of neuroplasticity that are so important in healing and recovery, which are intensity and challenge. So when we explain to patients why we want to induce symptoms, or why maybe we want to make you feel a little uncomfortable, whether that's fear or symptoms, this is why, because we want to retrain your brain, rewire, and make you tolerate the things that you once enjoyed that have been so avoidant of due to whatever reason. When we were talking about including feedback from your patients, one thing that I also do that I think patients really enjoy in helping build the connection in the relationship between provider and patient and that therapy alliance is I will check in with my patients now between sessions. So maybe if it's, I evaluated them today, but I'm not going to see them till next week for our follow-up session. I might check in with them in 3 or 4 days, and I won't say anything, but simply a check-in. How's everything going? Like, talk to me. And I think it does a couple things. It makes them truly feel like part of their care, but it also lets them know, like, hey, I care. I'm here. We are a team. Now, let's switch gears a little bit and let's talk about dual tasking, something you're doing right now. What is dual tasking and why do we use it?
So in reality, I have spoken, written, and prescribed a lot about dual tasking over the course of the last nearly 35 years, and it is the simultaneous performance of two tasks that can be performed discretely and measured separately. We can keep it that simple to start with. These are not complementary tasks that are done by body and mind toward one singular goal. There is a lot of, let's just say, technology that is developing in this space that pretends to be dual tasking, but it's actually just think and move. And so dual tasking needs to actually have two separate goals. Two separate goals. Even if your body and mind or body and body are doing two separate things toward separate outcomes.
So can you give us some examples of what a dual task might look like in vestibular therapy?
Indeed. So when we're working with an individual who is attempting to re-automatize their balance, and that's a primary directive for why we would dual task for a person with vestibular impairment, concussion, or hypofunction or otherwise. A common activity might be to load them with a cognitive task of their preference while we're loading them with a movement task that they're attempting to relearn. Let's be very clear about this. An individual recovering from concussion that perhaps is a multi-sport athlete, but we're in the season of soccer or football, depending on how you prefer, might be tasked to try to name 6 different Major League Soccer players while they are simultaneously dribbling a soccer ball down the field. The performance of iterating those players' names is a cognitive task. We call it in the subcategory of generation, having to generate information or recall information, depending on whether it's novel for them or not. And it has nothing to do and does not add to their capacity to dribble the ball down the pitch. So that's an easy one, and that's cognitive and motor. I'll give you one more example before I turn it back over to you. And let's consider that we may, in fact, have a visual and a motor. Now, we might experience that where an individual is attempting to hold steady, and maybe just the motor is just static balance on a compliant surface with eyes open. And what they're attempting to do, and when I've taken a very dizzying, optokinetically stimulating background and I've actually put it into their foreground, and I've put perhaps like a picnic tablecloth, hung it up in front of them, and I put a couple of football player cards taped onto there, and they have to, as I'm moving it around, name the players: Diego Maradona, Pele, Mia Hamm, and Abby Wambach, and let's say Alex Morgan. And we have to have them now participate in a visual task while they're attempting to keep the motor task quiet.
Sounds very similar to some of our patients who just want to walk through a grocery store with a dizzying, busy visual environment around them to remember what they're there to pick up and what they need to buy, while also staying nice and steady with their buggy, as they call it here down south.
Yeah, yes, absolutely.
That can be extremely important.
And both of our examples are going to have many consistencies, but one important consistency is that the loaded cognitive task is salient and very important to this person.
Yeah, that segues nice into my next question, which we've touched on a little bit, but can we talk about real life examples a little bit deeper? Let's talk about maybe specifically with parenting or household chores or driving, real life scenarios where we can attach kind of standard vestibular exercise with a dual task?
Oh, that's easy to do. So just consider the nature of actually turning to look out of my left rear view mirror, my left side mirror, and my right side mirror, and checking those mirrors at a frequency that doesn't feel artificial, doesn't feel prescriptive, doesn't feel therapy driven. Check left, check right. Nobody does that. Okay? We want to make it salient. And so if we have a mother or father of two that has to occasionally check on kids in the back seat as I'm driving, we might have a beautiful layer of a very intuitive task of side mirrors, rear view mirror, turn to look back even to see how the kids are doing. And we might have that as something that presents ultimately so much salience for the individual that, remember, the primary task is drive forward, which already has enough lamellar flow, visual optokinetic stimulus, that makes it a complex task. But the duality of it is, in fact, also checking on the kids. Remember, turning my head side to side to look in the side mirrors complements driving. That just more traffic, etc. That doesn't make it a dual task. It's in fact checking on the kids in the back that makes it a dual task, because now I have to cognitively interact with or monitor them.
I have been doing that a lot with cooking.
Yeah.
And a lot of my patients are having difficulty in smaller kitchens where they're constantly turning, looking, reaching. They're checking on the pot that's boiling, or the frying pan's that's on the stove, and making sure that doesn't boil over or burn. And they're having difficulties with tolerating that movement and paying attention, remembering what they're doing. So we've been doing a lot of things like that in our clinic to promote that neuroplasticity, that dual tasking, while pushing forward and doing those movements that are required for them to go from fridge to stove to counter. It's tough.
Yeah, and you know what? You bring up an excellent point, and we don't want to denigrate that just because a task is complex, that it's invaluable or not valuable, I should say, because it's not a dual task. We also need our patients to be able to task switch. And task switching, which is known as alternating attention, is not the same as divided attention, but both are salient, both are important. And Danielle, you're exactly right. You described some dual tasking in there, but you also described some task switching. So checking the recipe and then going over to conduct what you heard in the recipe, pour in a cup of milk, stir the batter, etc. Go back and check the recipe. That's not dual task, because those are all complementing forward toward the singular task of completing the batter, completing the recipe, but it's task switching. And our patients want to know that they're capable. And so, Abby, if we come back to what you said about 10 minutes ago, what we really want to tag on here, and you mentioned this, is that we want to do a degree of overtraining in the clinic that helps this individual feel strong, prideful, and capable. So I'm going to overtrain you in the clinic to the level that you permit me, so that you're a world beater when you go out there.
Yeah, we call that empowering our patients, right? That's exactly what we want to do. Now, what you're describing is increasing the level of intensity, increasing the challenge, but how do we know when a patient is ready for that?
So there's many ways to go. If we go back to the literature, I'm going to go to the optimal theory of motor learning, and I'm going to go to motivational interviewing as an approach. And so I may say, can you tell me how you feel that experience went? And if I want to use a rating scale to have them tell me what their symptoms are, I may do that. Here's where we need to go next level, though, what clinicians are not routinely doing at this point to answer your question. Let's say you tell me that provoked your symptoms to a level 4. Rather than me saying in a hierarchical manner, therapist here's level 4, and patient now must do this, Here's what we need to do to make certain that dosage is on point. Can't spell precision without person. I hear you tell me that provoked you to a 4. How would you like us to proceed with the next task? Would you like to have another task that provokes you to a 4? Would you need for me to reduce the intensity, or would you permit me to increase it from here? When patients are in control of the dosage, now they don't have to have the fear, the hypothalamic pituitary adrenal axis that promotes cortisol that we hear about in pain neuroscience. The same thing happens whenever they could be fearful that you're going to put the treadmill at 3.1. When they're in control, thank you for giving me the option to create the dosage. Now you lose all that super laden effect that you don't need of cortisol, of unknown, of fear, of can I do this? Because they are the ones that are kicking open the door. So I'm going to use autonomy and motivational interviewing. Here's how I heard you rate that. Where shall we go next? Based on what I heard from you, may I offer 3 different directions that we can go next? Because now that's saying, that's autonomy again. I'm still giving you some experience and some expertise. You're not wasting your $40 copay. I'm going to be informed about you. I'll tell you what are the 3 best options for you. Now we're working together. You choose which one feels healthiest to you.
I like giving that patient that power because I do feel like that vestibular dysfunction is very isolating, but very scary. And patients feel very much out of control of themselves, their situation, their bodies. So I really love that piece of advice. I want to start using that in the clinic like tomorrow, as soon as I get back to work, because so often, we check in with the patient, we ask how their symptoms are. We go, okay, well, you're nowhere near that 5. So let's go ahead and do a little bit more instead of being like, hey, how are we feeling? Are symptoms coming down? What are we up for doing next? Within reason, still being encouraging and hoping that we can push them along if needed. But I really like giving that patient the power. That's a really great point to make.
Yeah. And that's the thing, is that it just takes one more step. I already got your rating. Now I want to use your preference and your rating to our advantage. And remember, inherent in your response there, Danielle, I'm hearing you say, what if the patient actually continues to want it at a 4 and doesn't want to progress? A nice thing to reflect using motivational interviewing is, I'm remarking that the last 10 trials in a row, you've been at a 4 for this task. I'm wondering if now you feel that you've built up some confidence to go ahead and experiment to see if you can try a more difficult version of this, to see if it still provokes you to a 4, or how your body would respond to that, so that we prepare you for return to work.
So good. Now, again, shifting gears slightly, what would you say to someone who says to you, I had BPPV years ago, or I had a stroke years ago, or I was diagnosed with Parkinson's disease when I was 54, whatever it is? What would you say to them if they ask you, is neuroplasticity still part of their picture? And 2, what would you say to insurance companies who try to limit the number of sessions that a patient can have?
Okay, so I'm going to start with the first part and tell you that you and I, all 3 of us, and our listeners know that there is no time out to you've aged beyond neuroplasticity, right? Okay. Now, I want to be considerate of the diagnosis that this individual is presenting with, because we do know that there are some conditions where in a degenerative disease, I might not be able to make as much neuroplastic gain when they've advanced toward a more severe presentation of this condition. And I think largely about Alzheimer's dementia. Some of the more severe presentations advance in Huntington's disease, and potentially less so, but potentially some of the more atypical Parkinsonisms as well. Multiple systems atrophy, corticobasal, ganglia degeneration, etc. All right, so I'm going to leave some of those aside. Those are some of my worst case scenarios there, the severe end stage presentations of those. You've asked me to hear or say what I would say to a patient. And I'll tell you that here's about what I would say. Your brain has untapped potential to make new connections so that even if your disease is causing you to lose some, we can be at the same time getting the road crew out at night to make new connections, even if we experience some erosion of the roads during the day. The science is telling us that no matter how old you are, or even if you're facing the condition that we know you are, we can actually slow down the erosion of these roads. We have to get that road crew out there with intense work and work that feels important to your life. If I'm not dealing with a degenerative disease, then I want to actually talk with them about using the intact areas of their brain to rebuild connections back into the arenas that we've lost, because we talk about the fact that the brain has 83 billion neurons. And I like to tell people that each one of those neurons can make anywhere from 2 to 100,000 connections. And all we have to do is create a strong enough stimulus that your brain likes what it just experienced. So at night you lay down some new connections, because there are trillions and quadrillions of connections available to be made. Let's get out there and make some connections together.
I am putting that on repeat, because I will say, just personally from the clinic this week, I have a patient who has some neuro deficits following the removal of a brain tumor, cerebellopontine angle area. And they went to their 1-year follow-up with their neurologist, and they said, well, that's it. It's been a year. So what you've got is what you got. And
that's still being said?
That's still being said. It's driving me crazy. And thank goodness she is so tough and she's so determined. She's like, yeah, I don't believe him. She's like, let's keep going. So she's been making leaps and bounds with going through therapy. But it blows my mind that people are being told, it's been a year. You can't do anything more. Sorry.
Yeah, and let's take the sorry part of that, because I don't want to walk away from the second part of Abby's question. She asked about insurance companies, right? And so what we need to say there is, I'm going to hold myself accountable if I'm on peer-to-peer call and I'm talking directly with an insurance reviewer, which I've done hundreds, if not thousands of times. I've held myself accountable to objective measures to ensure that my treatment is making a measurable difference for this person. If you will allow us to move forward with these measures that demonstrate accountability, I am willing to subject the continuance of our care on the basis that we will make improvement in measurable, respected, recognized tools, or we will need to stop.
Yeah, now if only every person on the other end of that line would listen and be agreeable to that, we'd be in a much better position. But okay, so if we could kind of synthesize everything that you've talked about today, we've hit on fear, we've hit on neuroplasticity, we've hit on dual tasking, and kind of it all goes together, right? But you've had some mic drop moments. I want a mic drop moment for a clinician who's treating and then a patient who's undergoing care right now. What are your 2 mic drop moments for both of those?
Well, let's start off with the consideration. Let's go into dual tasking for a second, because sometimes patients can be a little bit confused or concerned why you are making the clinical task more difficult for me by adding a distractor. I've always heard it's bad to multitask, or this doesn't seem right. Shouldn't I be perfect at this? Why are you making me do it with divided attention or with a distractor? And what we have to say there is basically this. If we don't use the capacity to manage a distractor and remained movement proficient, and this is me just talking to you right now, we'll either lose it or leave that capacity in rehabilitation unrecovered. So now I talk to my athlete who is recovering from concussion. If I don't push your ability to divide your attention, I can return you back to the pitch, but we may never know if you were capable of recovering this attribute as well. So what we're looking at here is the thematics in play of use it or lose it. And if we were to think about the mic drop moments here, I might actually turn it to your audience to decide which of these that I'm kind of playing with in my head would be more powerful. I'll tell you this, if we don't task for it, we can't ask for it. That means if I don't create the task for you to participate in the clinic, you can't ask yourself to do it outside the clinic. So they can decide if they like that one, your viewing audience and listening audience. If we don't task for it, we can't ask for it. And maybe you like this one better. We can't expect what we don't reconnect. So I'll give you those two mic drop moments, and I'll let your audience decide in comments which one they prefer.
There's definitely a lot of perfect t-shirt sayings. We could open up a nice little product line from everything here. And I think that everybody listening might have a different takeaway or resonate with something a little bit differently, whether it's people who are fear avoidant or people who are unaware of what things are doing or people who are frustrated that they have to stimulate symptoms in order to get better. I think there's so much they can take away from your talk today that's going to resonate with everybody a little bit differently. And we appreciate you just bringing this knowledge to the table and letting us kind of piece it apart and break it down, because I think it's going to be extremely helpful for all of our listeners. So thank you for taking the time to do that.
Well, I appreciate what both of you professionals are doing with your podcast, with your audience. I appreciate being included on this journey with you. And thank you for your latitude in accepting my last minute AV technical glitches that are putting me on an iPhone and on a treadmill rather than in my normal recording studio. So I appreciate your latitude for that as well.
We are so appreciative of you being here. And if our audience wants to connect with you, where can they find you?
Well, it's very straightforward. Email address is just mike@mikestuder.com. Website is mikestuder.com. Social media is @MikeStuderDPT.
And audience, he puts out, I think, monthly blog posts, basically. Is it monthly or
Pretty
more?
much. I'm due for a July. I think I may have already released an early July one. I do about every week a 60-second neuro nugget on Instagram.
Yeah.
So I turn into that. And some of your readers or listeners, I should say, probably are familiar with the book that I published as well. It's called The Brain That Chooses Itself. And so that's empowering us to be whole and complete clinicians where we can talk about nutrition and sleep and social connectivity and physical activity, etc. So I've got my fingers in that as well.
You're definitely a great speaker, and I love the way you present what can sometimes be complicated subjects. So thank you again for bringing your knowledge to Talk Dizzy to me. And audience, thank you for joining us.
My pleasure. You all have a good evening.
This podcast is provided for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition.
The content of this podcast is based on general knowledge and information available up until the recording of this specific episode. Medical knowledge and practices may evolve over time, and new information may emerge that could change the understanding or treatment of vestibular dysfunction. It is important to consult a qualified healthcare professional for the most up-to-date and personalized advice.
The information provided in this podcast is meant to complement, not replace, the relationship that exists between a patient and their healthcare provider. It is intended to empower patients with knowledge about vestibular dysfunction and its management, but individual cases may vary, and treatment approaches should be tailored to each patient's unique circumstances.
By listening to this podcast, you acknowledge and agree to the terms of this medical disclaimer. The organizers, presenters, and creators of this podcast are not liable for any actions or decisions taken by individuals based on the information presented herein. Always consult with a qualified healthcare provider for medical advice and treatment.